Welcome to the Department of Medicine Grand Rounds today at the University of Missouri Kansas City School of Medicine. Today, in place of our Grand Rounds, we're privileged to have the Dr. Stanley Reitman Memorial Lectureship. First, a little bit about Dr. Reitman and this lectureship. Originally, this lectureship was entitled the St. Louis Friends of UMKC Lectureship. Dr. Reitman was very actively involved in initiating this lectureship from the St. Louis side. And Dr. Reitman was a very well-known clinician, teacher, and researcher in the St. Louis area and was president of the staff at Christian Hospital in St. Louis. He was very active in the St. Louis Friends group. At Dr. Reitman's death a few years back, the St. Louis Friends thought that in recognition of his long-standing service to the medical community in St. Louis and to his long-standing service to the St. Louis Friends group, that in honor of his memory, they would change the title to the Dr. Stanley Reitman Memorial Lectureship. This lectureship has been privileged to have many distinguished speakers over the past few years. This year is certainly no exception. Today we have for this lectureship, we're very grateful to have him join us, Dr. William Roberts, who is Chief of the Pathology Branch at the National Heart, Lung Institute and Blood Institute at the National Institutes of Health. Dr. Roberts has had a very distinguished career in clinical medicine, in teaching, and in research. He has been very active in the medical community in the sense of editorships and is currently the editor-in-chief of the American Journal of Cardiology. Dr. Roberts will be speaking to us today on coronary artery disease, the quantitative approach, and its clinical usefulness. None of Dr. Reitman's family could make it to the lectureship today, but they asked me to pass on to you their gratitude for joining us in this lectureship. And just for the interest of the group, Dr. Reitman had two of his children graduate from UMKC School of Medicine, Lori about 3 years ago, and Larry Reitman, who graduated last year. Welcome.
Well, thank you very much, Dr. Hamburger, for those kind words. Of course, I'm honored to be the Reitman lecturer, and I appreciate the invitation very much indeed. I'm sorry that the family could not be here. Go ahead with the first slide. This presentation has to do with coronary artery disease, of course, what the coronary arteries look like in various subsets of patients with the various clinical presentations of coronary disease. The latter portion of this will have to do with risk factors. Okay, this slide is an attempt to show how much narrowing is present in the major coronary arteries, major meaning right, left main, left anterior descending, and left circumflex, in a group of 129 patients with fatal coronary disease. Now, this slide shows what I like to call the qualitative approach, which is basically the angiographic approach. And that is, of the four major coronary arteries, how many of those arteries are narrowed greater than 75% at some point. Now, greater than 75%, I use the units cross-sectional area. That must be contrasted to the diameter reduction units of the angiogram. But in general, a 75% cross-sectional area narrowing is equivalent to a 50% diameter reduction. Now, this slide attempts to show how many of those four arteries are narrowed greater than 75% at some point by atherosclerotic plaque alone. And the answer is right here, which shows that on an average, 2.7 of the four are narrowed greater than 75% in patients with fatal coronary disease, irrespective of the various types of coronary event. One vessel artery so narrowed, only 8% of the group, which means that 92%, had 2 or more of these 4 major arteries severely narrowed at some point. We had some control patients. These were acute leukemic victims. The average there was 0.7, so quite a striking contrast. The major message of this slide is that coronary disease involves usually more than one artery, and it involves that artery severely. The disappointing thing about this approach was that we really did not see significant differences in the amounts of severe narrowing among these various subsets. And yet these various subsets from a clinical standpoint are strikingly different. The patient who has sudden cardiac arrest outside the hospital, of course, is quite different from the patient with angina pectoris, and yet the amount of coronary narrowing by this approach was roughly the same. So because we were not able to really correlate the amount of narrowing to the type of coronary event, my colleagues and I a few years ago went to what I like to call a quantitative approach. And that is, we took the same 4 major coronary arteries, took them off the heart, divided them into little 5-millimeter segments, and asked not only how many of these segments are narrowed 76 to 100% in cross-sectional area, but how many are also narrowed 51 to 75, 26 to 50, and 0 to 25. And what would you think? If we have an average of 54 5-millimeter segments per heart, which is an average of about 27 centimeters, how many of these little segments are narrowed that severely in a patient with angina, in a patient with acute myocardial infarction, in a patient who has an infarct which heals, has an aneurysm, has rupture of septum? Are there differences? Now, the reason I focus on the 76 to 100% cross-sectional area is that my engineering friends tell me, and a number have, that it takes at least 75% cross-sectional area narrowing, and probably more, in order to actually diminish flow through a tube, through a pipe, through a coronary artery. So narrowing of this extent is of interest, but is not meaningful. Now, from a functional standpoint. Now, the first subset of patients we studied were those that might be called sudden coronary death. A number of years ago, I had a trip to the Soviet Union, and my neighbor asked me, "Why are you going to Russia?" And I said, "Well, I'm on a delegation to study sudden death." He said, "Well, you couldn't have picked a better place to go." But of course, he was not talking about sudden coronary death. And to say coronary, at least one of the arteries has to be narrowed greater than 75% in cross-sectional area, in my judgment. So using a relatively strict definition of sudden death, this is what we found. The right coronary artery, as you may or may not know, in general is about 10 centimeters long in adults. The left main is about 1. The left anterior descending is about the same as is the right. And the left circumflex varies, but approximately 6 centimeters to study. Now that provides 27 centimeters of coronary artery, since we divide each centimeter into 2 5-millimeter segments. That's 54 5-millimeter segments per patient. The statisticians love this because it generates a lot of numbers very quickly, but that's the one to remember right there. 36% of these little 5-millimeter segments. In other words, about 10 of these 27 centimeters were narrowed greater than 75%. Now, the best way to remember that is to take a circle, divide it into 4 quadrants, and more than 3 of them were obliterated, greater than 75%. That's a lot of narrowing. So it's a wonder the patient really survived that long. Not that death occurred, or that death was sudden or non-sudden. Now, this slide asks the question, how much narrowing is present in the individual arteries? Is one artery more narrow than the other? Some of the old reports talked about the left anterior descending artery being the artery of sudden death. Is it? Does that mean it's more narrow than the others? No, look at there. The amount of severe narrowing, 76 to 100% of the 5 millimeter segments of these three arteries was similar in these three arteries. So if the LAD is the artery of sudden death, so is the left circumflex and so is the right. The left main, 10% of the segments of the left main were severely narrowed. Now this is a principle we found in every subset we've studied, so I won't come back to this, and that is that if one is dealing in groups of coronary patients, the amount of narrowing in these three arteries, or the lack thereof, is similar at each of the 4 categories of narrowing. Now what does that mean? With the individual patient, it may or may not mean too much, but when you say that this patient has single vessel disease, a common term, be careful. Be careful. Throw up the red flag. That's not the way coronary disease works. The same cholesterol level flows down each of those arteries. Same pressures in each of them. The same cigarette smoke, I presume, attacks each one of them. One of the principles that I thought was a principle, or heard in medical school, was that if one looks at coronary arteries, there's more narrowing in the proximal halves of coronary arteries compared to the distal halves. We looked at that in these patients with sudden cardiac death and divided these arteries into proximal half, distal half. Red's proximal, distal is yellow, and found no difference in the percent of segments narrowed greater than 75%. So just as much severe narrowing in the proximal halves as in the distal halves in these patients. Now it is true, if one studies coronary arteries in teenagers or those in their 20s, that plaques appear to start in the proximal halves, at least in the LAD and the left circumflex, maybe not in the right. But in patients with fatal coronary disease, that's not true. It's overall more or less the same. The next subset we studied were patients with acute myocardial infarction, transmural infarction. In contrast to the first group of patients who never made it into the hospital, these patients made it into the hospital, into the coronary care unit, but not out. And this is the amount of narrowing by atherosclerotic plaque alone. It does not include thrombus, and that percent there is similar to the percent in the sudden death group. So why did one patient have an acute infarction and in the sudden death group no infarction at all? Why? Well, the answer does not appear to arise, to be available by studying the coronary arteries. There was just as much narrowing. Now look at that percent right there, 5%. I've always heard that coronary atherosclerosis was a focal process, meaning that it's present in one artery and not in another artery, or it's present in one portion of one artery and not in another portion of the artery. Don't forget that 5% right there. That means that only 5% of these little 5 millimeter segments had narrowing 25% or less than 1 quadrant. That means that 95% of these patients had narrowing 25% or greater. So to think that coronary atherosclerosis is a focal process, at least in patients with fatal coronary disease, and I believe in patients with symptomatic disease, is to believe a myth. It's a diffuse process. Now this is a slide in a study done by Dr. Frank Brosius, a young person who worked with me. I think he came from Kansas here, and he came from this medical school. He came right out of medical school to spend a year with me. I thought I wouldn't get much out of him, just a kid, but yet he turned out to be one of the very finest people I've ever had in my 25 years at NIH, or 27. Did a wonderful job, and this was one of the studies that he did. Took 50 patients, all of these patients with fatal acute myocardial infarction, and we knew it was their first myocardial infarction, which was fatal. We knew it was their first because they had no scars in their left ventricular wall. And we asked two questions. Number one, if you take a group of patients with anterior wall infarction and compare the amount of coronary narrowing to a group of patients with posterior wall infarction, which group has the most coronary narrowing? Well, what this slide portrays are the percent of these 5mm segments that are narrowed over 75%. The green actually are the percent narrowed 76 to 95, and the red, the percent over 95%. And what this shows, if you just look at this bar and this bar, is that the group with a posterior or inferior, as some of the cardiologists call it, I don't like to use that word particularly, the posterior group had a larger percent of segments severely narrowed. The second question we asked in this study was that if you have an anterior wall infarction, does that mean the left anterior descending is more narrowed than the other two arteries? Or if one has a posterior wall infarction, does that mean the right or the left circumflex is more narrow than the LAD? We all know that if you take a dog or a cow or another non-human animal and tie off the LAD, one gets an anterior wall infarction. If one ties off the right, one gets a posterior wall infarction. Is that the way it is in human beings? Well, when we looked at that in the posterior wall group, and this is narrowing by plaque alone, does not include thrombus, the left anterior descending was just as narrowed as either of the posterior perfusing arteries. So this was not true in humans with a posterior wall infarction. In humans with an anterior wall infarction, the LAD was a little bit more narrow than the other two, but all three arteries were narrowed. Now, it is true if one has a thrombus that the thrombus is properly located, and that is if one has an anterior wall infarct, the thrombus will be in the LAD, and there are just no exceptions to that. If one has a posterior wall infarct, the thrombus is either in the right or the left circumflex. But plaque, atherosclerotic plaque, does not necessarily follow or determine the location of an infarct. Now, this slide summarizes two studies. One of them symbolized by this diagram. We took a group of 18 patients who had a myocardial infarction which healed, but after healing of the infarct, the patients were left with chronic congestive heart failure, which became intractable and eventually fatal. This group could be called, I'm sure Dr. George Birch would call this group ischemic cardiomyopathy. We contrasted the findings in them, that is the findings in the coronary arteries, to another group symbolized by this diagram. This was a group also of 18 patients who had a myocardial infarction which healed, but after healing of the infarct, they never again had clinical evidence of myocardial ischemia. They never had a second infarct, they never had angina, and indeed, they died from a non-cardiac cause, usually cancer. So here is a totally asymptomatic group after healing of an infarct, and here is a very dyspneic group. Now, which group, logically, would one suspect had the most coronary narrowing by this quantitative approach? When we looked at that, the percent of segments narrowed 76 to 100%, 29% here, 31% here. No statistical difference. Percent of segments narrowed 51 to 75, 37% here, 35% here. Now, the point of this is that if one has chronic congestive failure after healing of an infarct, it generally means the infarct is quite sizable. So these patients had large infarcts. These, as a group, had relatively small infarcts. This study shows that the size of an infarct is not proportional to the amount of coronary narrowing. When I was a house officer, I remember ward rounds, and the visitor would say, I remember a few patients, so this patient had a small heart attack, meaning I presume that this person is going to do all right. Small heart attack is not very dangerous. Well, it's very dangerous. Actually, the mortality may be quite high at a year in the so-called person with a small heart attack. But from the standpoint of the coronary arteries, it doesn't matter whether the amount of coronary damage is small or large. There's a lot of coronary narrowing. Now, this is a busy slide. I apologize. The area I want to focus on is this bar here, just that portion, and this bar here. This study was done with another young fellow, Dr. Henry Cabin, and what we did was take a group of hearts which had transmural scars in the left ventricular wall. And we subdivided these cases into those with anterior wall infarcts and posterior wall infarcts, which had healed, just like the acute group. And we asked the same question. If one has a healed infarct in the anterior wall, does that mean more, less, or similar degrees of coronary narrowing as the group with posterior wall healed infarcts? And what we found was similar to the acute group, that the posterior wall scar group had, as a group, more severe coronary narrowing. This displays the percent of segments narrowed 76 to 95%, and the percent narrowed over 95% in black. So again, whether acute or whether healed, the posterior wall infarct group had more narrowing. Now, as you may or may not know, about half the myocardial infarcts are clinically silent. Or if they are not silent, the person never tells anybody about chest pain. The major study on that was at the Mayo Clinic by Edwards and Burchell in the 1950s. So what we did in this study, summarized here, was to take a group of 16 patients who had healed transmural scars at autopsy, but never during life a clinical event compatible with an acute myocardial infarction, silent. And we compared the findings in them to a group of 23 patients who had classically recognized clinical event compatible with acute myocardial infarction. It's not easy to be sure of these groups, so we had to eliminate most patients. These 16 were followed for many years by private physicians in Washington, so we could rely on the history. And we asked a simple question. Do the coronary arteries know if the infarct is silent or clinically apparent? Is it better to have a silent infarct or a clinically apparent infarct? Which one has the most coronary narrowing? And we found when we looked at this from a qualitative approach, that is, how many of the 4 major arteries are narrowed greater than 75% at some point by plaque, 3.1 in the unrecognized, 2.8 in the recognized, no significant difference. When we looked at it from the quantitative standpoint, percent of segments narrowed 76 to 95%, 38%, 35%, 7%, no difference. So the coronary arteries appear not to know whether the infarct is silent or not silent. We concluded from that study, the numbers have increased a little by this time, that the silent group, the non-recognized group, have more frequent diabetes. That's well recognized, I think, but the numbers on it are not so good. The unrecognized group had smaller sized infarcts as a group, and therefore much less frequency of congestive heart failure. They had a more posterior location, much more than anterior, but there was no difference in the amount of severe narrowing. Now, this slide attempts to show the difficulty in studying a group of patients at necropsy whose only manifestation of myocardial ischemia during life is angina pectoris. Now, does a person die from angina, in other words? If one has angina pectoris, most individuals with angina die suddenly. Then at necropsy, they're put in that category. Or they have an acute myocardial infarction, then at necropsy, they're put in that category. So to get a group of patients whose only clinical manifestation of myocardial ischemia was angina is not easy. We picked this group here and said that these patients went to bypass operation because of angina, or they had sudden cardiac arrest inside a cath lab, and studied them and said, this is maybe what the coronaries look like in angina. Well, it turned out there were 22 patients. All of them had unstable angina. One patient was taking over 50 nitroglycerin tablets a day. Angina was getting progressively worse. So this is a select group. I hope that this data is not applicable to the patient who has angina once a week or once a month or less often. All of these patients had cardiac catheterizations. In all 22, the ejection fractions were normal. Left ventricular function was considered normal in all 22. And look at this number percent right there. 48%, nearly half of that coronary tree, 5 millimeter segments, were narrowed over 75%. And yet, left ventricular function was entirely normal. In other words, the amount of coronary narrowing does not tell you how this left ventricular wall is functioning. So this was the most narrowing of any group. There was a suspicion of that from the qualitative studies, but it was confirmed here. 11% of the segments were 25% or less. The other difference between the angina group and the other groups was that this was the only subset where the left main coronary artery was higher than 10%. Here, the amount of narrowing in these three arteries, severe narrowing, was similar, but these three arteries were joined by the left main, which was 40% of the left main segments were over 75% narrowed. The other difference in the angina group, this was the only subset we've studied where there was more significant narrowing in the proximal halves of these three arteries as a group than in the distal halves. Obviously, that's, thank goodness, from the standpoint of a bypass operation. But that's the only subset that's been that way. Now, this slide summarizes these quantitative studies. We've studied 129 patients by this approach. That's about 6,500 5 millimeter sections studied under a microscope, which really is a lot of acreage to study under a microscope. You paid for this. Taxpayers paid for it, so I'm grateful to you. I'm not sure a grant somebody filling out a grant would receive money because of a study as simple as this. 35% of those 5 millimeter segments were narrowed 76 to 100%, and another 36% were narrowed 51 to 75% by atherosclerotic plaque alone. Only 8% were narrowed 25% or less. Among the various subsets of coronary patients, the sudden death group and the acute myocardial infarction group had similar degrees of severe narrowing. The group with healed myocardial infarction as a group had a little less, significantly less. The unstable angina group had the most narrowing of all. We used another method also to try to get a single number for each patient, and that is to assign a score, a number, to each 5 millimeter segment. So a 5 millimeter segment narrowed to this extent would get a score of 1, 2, 3, 4. And it turned out the mean score for all of these patients was about 3.0, for the controls 2.0. Now, what does that really mean? It means this. It means that about 6,500 5 millimeter segments, the average amount of narrowing in each one was about 67%. Controls about half of that, 32%. Now, when one is looking at angiograms, don't forget that that's the area that the contrast material is flowing, but not in here. Now, the question came up in this presentation, clinical usefulness. Is this quantitative approach clinically useful? Let me show this first before trying to answer that question. This is a montage of 5 millimeter segments. Each one of these represents a section of a 5 millimeter portion of a coronary artery. This is the right, in a patient with unstable angina, and try to find a coronary segment that's normal or near normal. This is the left main here, terribly narrow. Left anterior descending. Look at here, very narrowed, way out. That one's pretty good, pretty good. Left circumflex was dominant here. Look way out in the left circumflex, terribly narrow. And that's what the patient and that's what the doctor is up against. In at least, and I think in a symptomatic patient. I think the big change in coronary disease is not between onset of symptoms of myocardial ischemia and death, but between asymptomatic state and symptomatic state. Now, I don't particularly like to push the diffuse nature of atherosclerosis, coronary atherosclerosis viewpoint, because it makes one a little pessimistic and cynical. But I'm afraid it's true. Here's a end arterectomy specimen of a right coronary artery. And this is where the ostium is of the right coronary artery, and that's a little posterior descending there. And the reason I show this is this is the reamed out core of a coronary artery at operation. And I show it to point out that the entire artery is involved by atherosclerotic plaque. To believe that coronary disease in a symptomatic patient is focal, that you see a plaque one place and not in another, is a dream. I wish it were so, but it's not. Now, does this quantitative approach have any clinical usefulness? If one wants to find out the status of the coronary arteries during life, there's just no substitute for coronary angiography. When I get chest pain, which I think is myocardial ischemic nature, I want to have a coronary angiogram. But there are limitations to coronary angiography, just like there are limitations to the histology technique that I've been approaching. For example, with an angiogram, one uses the units of diameter reduction. I've been talking about cross-sectional area narrowing. In general, a 50% diameter reduction is equivalent to a 75% cross-sectional area narrowing. But what is this based on? One cannot see with contrast material the internal elastic membrane here and here. So one is basing that on an adjacent area which is assumed to be wide open, assumed to be normal. But is that the real world in a patient with symptomatic coronary disease? And my answer, unfortunately, is no, it's not the real world. This is probably the real world here, and one is comparing an area of narrowing to an adjacent area which is assumed to be normal, but in actuality is almost surely simply less narrowed. So rather than that being a 75% diameter reduction, if we had the luxury of visualizing the internal elastic membrane, this becomes a 50% reduction, because this is already 50% narrow. We've done a couple of studies comparing the histology approach that I've talked about and the angiographic approach. Ernest Arnett was the key person in one of these studies, and Jeffrey Isner in the other. And what we found is summarized here. I won't go into the numbers, but mild degrees of coronary narrowing are rarely misdiagnosed angiographically. And what that means, and this is wonderful, is that if you have a relatively clean coronary tree by angiogram, one can be confident that that coronary tree is relatively clean. So that's a wonderful bit of information. Moderate degrees of narrowing, and this is the real no man's or no woman's territory, a narrowing of 51 to 75% reduction in cross-sectional area, that is usually underestimated angiographically. We did a study of severe narrowing of the left main coronary artery. And then a group that had left mains narrowed 51 to 75% cross-sectional area. Not a one of them were diagnosed properly by angiogram. All were considered normal. Severe narrowing, unfortunately, is often underestimated. And the diffuse nature of the coronary atherosclerosis in patients with fatal coronary disease, and I believe symptomatic, is a major cause of the angiographic underestimation, because more narrowed areas are simply compared to adjacent less narrowed areas which are considered normal. Now again, does this quantitative approach have any clinical usefulness? This is a right coronary artery with contrast material in a patient studied at NIH who had severe angina pectoris. The left anterior descending coronary artery was severely narrowed. The left circumflex system was severely narrowed. This patient was going to have a bypass operation. There was no question that he needed a conduit to the left circumflex system, to the left anterior descending system. Would you put a conduit in this right coronary artery? Do you believe the viewpoint that coronary atherosclerosis is a diffuse process or not? Is coronary narrowing limited to 2 arteries? Is the 3rd artery spared? Is this artery really normal? There was thought to be a little irregularity here. The judgment was made that this artery looked pretty good. It did not warrant the insertion of a conduit. The patient had a bypass operation, unfortunately did not make it, and these sections of coronary artery were prepared from that right coronary artery, the angiogram you've just seen. Now, the thing to notice in these coronary arteries, and these numbers represent the number of centimeters from the aortic ostium, is that these coronary 5mm segments are not normal. Every one has atherosclerotic plaque. That's a lot of atherosclerotic plaque. That's the way coronary disease is. It does not attack 2 arteries and spare the 3rd one. Now, the other question is just because an artery has atherosclerotic plaque in it, that does not necessarily mean that it is significantly narrow. Are these arteries significantly narrow? Now, the lumens here look pretty good. They stretch from one diameter to the other. This would expand even more if it were pressure in here. But that lumen is pretty good. Down here, it's not so excellent. Now, if that had been me, and I was going to have a median sternotomy, and my left circumflex system was severely narrowed, and the left anterior descending was severely narrowed, I don't really care what the angiogram showed on the right coronary artery. I would want conduits inserted in all 3 systems. Now, I don't base that viewpoint on just that single case study. I base it on this study. This is a study which summarizes the study. We took a group of patients who had a bypass operation and they didn't make it. Some of the patients died within 60 days of the procedure, and others lived for years after the procedure. And the question we asked was this: if one looks at the native coronary arteries, forget about the conduits, just the native arteries. The native artery, is there more narrowing in the native arteries that were bypassed, or more narrowing in the native arteries that were not bypassed? Now, I would say that these arteries were not bypassed because the judgment was made from the angiogram that the artery was not narrowed sufficiently to warrant the insertion of a conduit. It was not bypassed because it was too narrowed or because it was considered too small. It was not narrowed and it was not bypassed because the judgment was made that it didn't need a conduit. And look what we found. Now, just look from here to here. Now, these are the percent of 5mm segments of the native artery which were narrowed 76 to 95%, and the black, the percent narrowed 96 to 100%. Now, what this shows, whether the patient died early or whether the patient died late, was the amount of narrowing, of severe narrowing in the native arteries which were bypassed was no different from the amount of severe narrowing in the native arteries which were not bypassed. And when I have my bypass, I want 3 conduits, 3 anastomotic sites in the aorta,